Actually, just to give you an update on last case, we were wondering if this patient may have early lymphoma. And at that time, I did ask my hemopathologist to have a look again. He actually assures me at this time there is no evidence of lymphoma. But I'm going to put a paper on top of that, which came after I found that after I had presented those rounds. You can have similar picture what our patient had. The patient was described from Japan, and actually they treated him as a drug-induced interstitial nephritis. But when they examined his urine, I don't know how they found those atypical cells. I can't find even in my lab those kind of cells, but they found, and they did some marker studies and turned out to be a T-cell lymphoma and had no other manifestations of T-cell lymphoma. And his creatinine and his course after doing the CHOP was actually very good. The second question which I was asked, and Dr. Radby, I also brought it yesterday at New York conference, and Dr. Radby was there too. And I had mentioned that actually we should think about anti-nuclear antibody sometime as monoclonal antibodies, because I have seen a number of patients with these monoclonal antibody having anti-nuclear antibody positive, and we could never explain. So I found this patient paper, and this actually was done in Columbus, Wexner Medical Institute. And we will post it for you. You guys can read it and think about that. Generally, what I remember when they did the subclassification, it was IG2, which was more like behaved like a monoclonal. And what is interesting is that when you treat these patients, these ANA disappears. So it's just for food for the thought, because we never discuss those. We just ignore them. Maybe they are nothing, but this paper is very interesting, and people can read it at their leisure. We'll post it for you. Now we're going to go to this next case of ours. It's an interesting case which I saw in 2018-19, exactly 1 year before COVID pandemic. And this case actually taught me a lot about COVID pandemic itself. And I was able to use that experience in managing whatever COVID patient I saw. This is, I will present in a different format actually. One, we will present the history, then the course, then we'll have a little poll, then we'll do our biopsy and discuss the nephrological aspect. But I also want to bring in my hematology and ICU colleague, because I think it impacts them also, and I will give them my perspective. So let's start the case, if it is okay with anybody. Any questions about the previous comments, I'd be happy to take it.
Well, thanks. Thanks.
All right, so we'll get started with the next case. So we have a 29-year-old female who's returning from a week-long vacation in Jamaica. Prior to leaving the vacation, she did feel malaise, weakness, nausea, but she made the trip home anyways. And when she returned, her symptoms worsened and she started to note myalgias, arthralgias. She also noted epistaxis, vaginal bleeding, and bloody diarrhea, which all brought her to the hospital. Her past medical history was significant for gestational diabetes with her pregnancy the previous year. On review of systems, she had no chest pain, no shortness of breath, no cough, no sore throat, no blood in the sputum, no neck pain. She was not taking any medications when she presented to the ER. Her family history was otherwise unremarkable. Social history, she was a non-smoker, no use of alcohol, no use of recreational drugs or over-the-counter medications. On physical exam, her blood pressure was 120/70, heart rate was 110, and temperature of 38.2, with a O2 sat of 98% on Revere. The cardiorespiratory exam was normal. There was no edema. Abdominal exam was normal at the time. There was no hepatosplenomegaly noted. On presentation, her creatinine was 115 with the eGFR of 57 mils per minute. Her creatinine was 87 the year before. Hemoglobin was 140, platelets 56, white blood count was 5.4, lactate of 2.4. Her AST was elevated at 617, ALT 215, ALP was 70, and CK was around 2,930.
So the poll is that what's your top differential diagnosis of this patient? So basically, she comes from Jamaica with malaise, fever, and feeling unwell. What do you think is going on? You can. It's a anonymous poll, so you can stick in what you want to say. So can you show us the poll, Chef, if it is done? Deepika?
Yep, we're just pulling it up.
Okay, that's very smart. Most people said dengue. I'm surprised they didn't say chikungunya fever. Actually, this is very prevalent in Jamaica. And the patient will present exactly like this, but they may have some arthritis also. They can have some joint swelling and all those things. Also surprised you didn't choose leptospirosis. It's very prevalent in Jamaica. And generally people are very jaundiced with that. Yes, dengue fever is very prevalent in Jamaica. Hantavirus we put in there because at that time there was a epidemic outbreak at that time near Panama and South America and in some of the Caribbean islands. So that's why we put that both. Okay, so let's see what that patient has. Go forward.
So after she presented to the hospital, she ended up being admitted to the ward and she was managed with IV fluids. By day 3 of her stay, her condition worsened and her creatinine rose to 650. She developed a maculopapular rash on her face, torso, and limbs. On exam, her blood pressure was 115/73. Her rate was 120 and her temperature was 39.3, and she was sitting at 94% on room air. Her mucous membranes were dry. She had the erythematous maculopapular rash on her face, torso, and limbs. Her cardiorespiratory exam was normal. She had no edema. Abdominal exam was also normal, and there was no hepatosplenomegaly noted on exam. And we will review her blood work. So during those the few days, her creatinine rose from 770 to 960, the functioning around 6 mils per minute. Her hemoglobin dropped to 90 and platelets down to 37. Her potassium was 4.2, sodium 138, and bicarb 23. Her calcium and phosphate were within range. Her albumin was low at 18. In other blood work, her ferritin was fairly elevated at 29,000. Her haptoglobin was elevated at 2.45. ALT was high at 840. ALP was 67. Her LDH was around 3,480. Her triglycerides were elevated at 8.4. Fibrinogen was 2.0 and ESR was 36. Urinalysis showed 3+ protein and 3+ blood. In other blood work, her rheumatoid factor was negative, ANA negative, double-stranded DNA was slightly elevated at 48.5, ENA was negative, C-ANCA, P-ANCA were also negative. Complement level C3, C4 were also within normal range. Our IgA, IgG, and IgM levels were also within normal range. Anti-GBM by ELISA was negative. Free light chains, free kappa chains showed were elevated at 183. Free lambda chains elevated at 136, and the kappa lambda ratio was 1.35. She did have further complement studies with C2 measuring at 36, slightly elevated. Complement level C5 was 54, and total complement or CH50 was 74. We did also run an Adams T13, which was 0.67. The ultrasound.
Just before you go, Deepika, these studies were done after I had seen her. When I was called, she was already seen by my colleague from infectious disease, and she suspected dengue and had ordered appropriate test. Because when she was admitted on the floor, but she's continued to get deteriorated. Her history is a little bit more, slightly, I would like to add something. She actually became sick in Jamaica itself, and then she came to Canada. Actually, I happen to know the doctor she saw in Jamaica, and he suspected dengue, which is very common in Jamaica. And then she flew to Canada. She was at home. Then she started to have some rash, some blood in the sputum. We are not sure it was nosebleed. And her periods also expanded and felt unwell. And she came. So the time period is about 5 days, 7 days before she came to the hospital. So the interesting point is that these patients actually get better by day 5. But if they persist fever after 5th day, you got to worry about these patients. So that's why I ordered all these tests. Okay, go forward.
Yep, and to finish off, her ultrasound showed right kidney measuring 12 centimeters, left kidney was 11 centimeters. They were both echogenic. She did have fatty liver measuring. It was enlarged at 21 centimeters, and her spleen was also large at 15 centimeters.
So the poll 2 says that, what is your diagnosis? What was the cause of her acute renal failure? I can tell you that her creatinine about a year ago was around 58 micromillimole, which is normal for her age and size. So what do you think what's going on? Again, this is anonymous and you can vote freely.
Jinder, are we allowed to ask questions?
Sorry?
Are we allowed to ask questions?
Of course.
Was there any signs of fragmentation, hemolysis, retic count, any of those things done?
No, there was no fragmentation. Her haptoglobin was high, and there was her LDH was high. I think she showed the values. It was quite high. There were no fragmentation in her peripheral smear.
Thanks.
So if you are thinking that if she has AHUS or TMA, at least from lab value, there was no evidence other than high LDH. Okay, but I should suggest you, Dr. Corvella, is that you don't have to have fragmentation all the time, especially in hematological causes of TMA. You may have no fragmentation, your LDH may be normal. So putting so much emphasis on that is, it can lead to a mistake. So just want to remind people that it helps you, but if it is absent, that doesn't rule it out. No, Dr. Radhi, she wasn't sick. I think that was misinformation. When she left Jamaica, when she left Canada for Jamaica, she was not that sick. Okay, what are the polls? Can you show us the poll? So acute tuberous necrosis, rhabdomyolysis, TMA, and HUS, and focal segmental glomerulosclerosis. So there is a wide variety of diagnoses. And as Dr. Radvi says always, that's why you do biopsies. So here is the biopsy. So just before we go biopsy, just want to show you guys that most common causes of acute kidney injury and dengue is actually direct effects of it, just like COVID actually, ATN, hemodynamic changes, rhabdomyolysis. Some cases are glomerulonephritis, they have been described, but very few biopsies have been done. And there are few cases of AHUS have been reported in these patients, and they were treated with ocrelizumab, but not many. When I review the literature, actually, I could come up with the 20 biopsies since 2021. So there is not much information what exactly the underlying kidney disease is. Okay. So we made the diagnosis of actually on the criteria that was my diagnosis, that this lady has suffered hemophagocytic syndrome, macrophage activating syndrome due to dengue, and it has been reported. And my reasoning was that she had very high ferritin. I had never seen ferritin at 28,000, and she had high triglyceride. She had hepatosplenomegaly, and she had cytopenias, and she fulfilled the criteria of macrophage activating syndrome. So we felt dengue was the cause of macrophage activating syndrome. It's a very serious complication. And so she was transferred to ICU before even I came. And she was quite uremic. She was very unwell at that time. Blood pressure was around 90/60. She was oliguric, and then she was started on dialysis. So we were suggested that she may have macrophage activating syndrome due to dengue. And here is a paper for you guys to review. Okay. Go ahead.
So during the course of her hospital stay, her creatinine continued to rise. It was over 700. She had oliguria and uremic symptoms. She was started on CCRT and started on dexamethasone, 8 milligrams every 6 hours. She did recover in 2 weeks, but then continued to have 2+ blood and 2+ protein on a non-catheter urine specimen. Her 24-hour protein was 2.2 grams per day with the urine output of 1,000 cc.
So the reason I chose CRRT, we are actually we have a very robust ICU program, and I really believe it is one of the best programs in the GTA, Greater Toronto Area. And we have all the modalities except PERT, with Dr. Darby uses. So we have SLED, we have CRRT, and of course we have intermittent hemodialysis. I chose actually CRRT with the basis of, with the very old theory in 1999, that it can remove cytokinin, and this was again came back and forth in front when COVID came. Actually, we were all talking about is there any ways of taking cytokinins by prolonged dialysis, such as CRRT or PERT or SLED. So we chose CRRT, just speculation, knowing that it has never been proven. But I remember that paper in 1999 from, I think it was from Italy, that you can remove cytokinin, and this is a cytokinin storm in my opinion. So that's why we used it. If anybody has any comments about the modality, I'd be happy to hear it. Any comments, Dr. Radby? You use a lot of PERT.
I don't, well, most of those cytokines are too big to cross the membrane, but I'm a huge fan of any form of continuous renal replacement therapy, and I would have, of course, used that in anybody that's sick. So, but most of those mediators are just too big to significantly cross. Seeding coefficients are like 0.1, but people have reported some effect.
Okay, the biopsy time. Okay, Dr. John, take over. It's your show now.
Deepika, are you going to move the slides, or
I'll just give you control. Give me 1 second.
you can just move it? It's okay.
There you go. You should be able to move them now.
Okay, great. So that's a low power trichrome, just to show some background lack of fibrosis. In this case, it's a pretty pristine biopsy. Tubules are dilated, consistent with some ongoing tubular injury. Lots of tubules, there's some red stuff in them. They're not red cells. It's just protein resorption droplets engorging the tubules. There were about 17 or so glomeruli. None of them were globally sclerosed. And I have here 4 glomeruli, quite representative of the entire slew of glomeruli seen in the biopsy. So there's one at the left top, which was a rarity, minimally shrunken, but otherwise quite unremarkable. The 2 on the right show some balloon-like cells in Bowman space, loosely podocyte type cells. And on the glomerulus at the left bottom, only a portion of the glomerular tuft, segmental, that is the right side, has those cells in Bowman space. The tuft is not that clearly seen where the cells are big, which is one clue that probably the capillaries are collapsed. And we like to use that word collapsed in a very specific instance in the field of renal pathology, which shows up much better on a silver stain that shows those wrinkled and now collapsed capillary walls or basement membranes with those big cells in Bowman space that I'll show you as a single glomerulus on a high power that has vacuoles and resorption droplets. We can say podocytes, podocyte type cells. Some people claim they're parietal cells. Some people say they're like some stem cell-like cells coming out of Bowman capsule somewhere. Either way, podocytes, hypoplastic, hypertrophic podocytes with collapsed capillary walls, quite typical of collapsing glomerulopathy. A few glomeruli showed a little bit of, I'm interpreting as non-specific staining for IgM, but all the other immunoglobulins and complement components were negative. Electron microscopy, even at this sort of low power on the left side, one does not see the feet of the processes, meaning that they're effaced. And on the right side, one sees those black-like globules, which are, again, loosely protein resorption droplets in the podocytes that we saw on light microscopy. Interestingly, by the way, there were tubular reticular inclusions consistent with systemic interferon, mostly type 1 interferon activation. And this is where the interestingly part comes in, that there were 2 glomeruli on electron microscopy, similar to what we saw in light microscopy, that didn't show those segmental or global collapsing lesions. And in those, again, I say interestingly, the foot processes were relatively preserved. We like to think of the loosely put podocyte diseases, podocytopathies, as having diffuse impact, even though the lesions are only seen morphologically in some glomeruli. But here was one instance where they were relatively preserved in the unaffected glomeruli. Given the morphology that I'm showing you, I wonder whether the proteinuria was 22 grams or 2.2 grams, but nonetheless, it is what it is. So here was the diagnosis.
Dr. John.
Well, I must object just a little bit calling this a diagnosis. This is a microscopical description of pathology. This is not a diagnosis. So I think the terminology here has to be very precisely used. We don't know what the diagnosis is.
I mean,
Maybe
I'm not going to disagree with you given your status, but I'm not going to entirely agree with you because it is a pathologic diagnosis. Now, they can be a clinical diagnosis, they can be a proteomic diagnosis, they can be a transcriptomic diagnosis, they can be a genomic diagnosis, but I'm going to stick to this is a pathologic diagnosis. And sure, it might have about 800 causes, just like TMA does, and it still is a diagnosis.
He did,
Okay.
Rick, he did put biopsy diagnosis. He threw that in just for you. So Rohan, would you have said there was also ATN? Because it would have probably, I would say there's more than one process.
Yeah, sure, but generally in the context of something like collapsing in particular, yeah, it goes along with it. And I would have put it in my comment that there probably is a quite significant acute tubular injury.
Curious, do you think there was some microcystic dilatation as well, or it was just all ATN?
It was ATN, engorged resorption, tubule sort of full of them, but not the microcystic dilatation that people describe in a good proportion of cases of collapsing glomerulopathy.
Now, if you had put on the diagnostic line of this biopsy ApoL1 nephropathy, then I would be very satisfied. We don't know what this patient's ancestry is, and we don't know her ApoL1 status. You didn't tell us that. But I will, again, take exception with the use of a descriptive terminology to make a diagnosis, but we won't settle that argument today. So we'll just have to disagree on that point.
So, Dr. John, in your previous biopsy report, if I recall, you had suggested that this collapse this pathological lesion was because of histiocytosis. Do I remember correctly?
I mean, I'm influenced by knowledge of interferon, histiocytosis, ApoL1, and so many things. I have seen reports of the collapsing variant in malaria, for example, in other viral infections with and without hemophagocytic lymphocytosis. So I'm not sure whether I necessarily suggested that, but if it was there, then I'm not going to detract from it.
Okay.
Did this patient actually have dengue fever? I mean, was it? You may have shown it, but was she actually diagnosed with that?
Actually, I'm going to bring my infectious disease specialist who is, I think she's Maheen. Actually, Dr.
Yes.
Becky saw her, and
Yeah.
I think her IgM was positive, which
Yes.
dengue.
Definitely.
And what was interesting, she had IgG positive too. So she has previous exposure to dengue, and I think that's important. And then she had another variant. Go ahead, Maheen.
So she definitely did have dengue fever. And when I brought her down to the ICU, I really thought she had dengue shock syndrome. That was my initial concern. This was before, I think I don't really remember the case very well, but I think this is before all of the ferritin and everything came back. So I was really thinking that she had dengue shock syndrome and she had superinfection as a consequence of her return trip back to Jamaica. So that's what I was worried about, because she was in that febrile phase and the critical phase of her illness. So as you recall, or you may recall, dengue has a very short incubation period, usually about 7 days following a bite from the Aedes aegypti mosquito. It's an urban disease. You have the febrile phase, the critical phase, and the convalescent phase. So if you have superinfection with a different serotype of dengue, you can get dengue shock syndrome or dengue hemorrhagic fever. And I was worried about dengue shock syndrome in her because she had that terrible critical phase of her illness. And that's what I was worried about. And that was made me concerned. And that was what I thought was the cause of her acute kidney injury, because she was having, I thought that was the cause of her acute kidney injury because she had had a superinfection. But she definitely did have dengue, and she had this was, I think, her second infection. Sure,
the point Dr. Packy is trying to make is that dengue is a very unique disease. If you have second infection, actually that is more dangerous. And generally, if it will be a different subvariant which will affect, it will give you if I remember dengue, I had dengue myself, so that's why I know this thing. If it lasts you, it gives you a protection for about 3 months. But if you get second hit with a different variant, it has 4 variants. What happens that the theory is that new infections actually reacts with the IgG, which is present from previous infection, and that has more attraction to the mast cells and the mononuclear cells, and causing all these kinds of cytokine storm. So that is why Dr. Becky is saying superinfection, because it was a second hit. So it is important to know that, because she's actually a Canadian, Caribbean Canadian. Dr. Glassett was asking me, she has a Black ancestry, so there is a possibility she may have APOL1. genotype. Very strong possibility, actually. And so that's why we felt that this girl will be in trouble, because that was a second hit, as Dr. Packy said.
Does she have West African ancestry?
No, she was Jamaican. at
Jamaican.
100%.
Well, many Jamaicans who are Black have West African ancestry.
I
That's right.
think Jamaican mostly are coming from Ghana and South Africa, Dr. Glassick. I lived in Jamaica for 2 years, so I have a little bit of knowledge about that. But yes, but I couldn't tell you what her ancestry was, but she was definitely, family came from the continent of Africa. I actually ordered
Well, I would
APO1.
do an, I mean, I would do an APO1 high risk alleles in this patient.
We actually ordered when she was admitted, and my hospital thought something else, and they did apolipoprotein serum. And so that was low, which I expected. But we have sent the APOL1 studies. Actually, we are waiting the results. We have already sent that.
Yeah.
See, in Rush, we would have called this the cellular lesion. This was
Yes.
before the Degati classification. You know, Mel and Ed basically felt that the lesion here is in the podocyte, not in the capillary, which was the huge argument between us and other groups. And when she came out with the classification, the cellular lesion really became endocapillary proliferation. But if you read our old papers, the cellular lesion was really synonymous with collapsing FSGS. We just kind of emphasized the fact that it was the proliferating podocytes that were where the lesion really was. Anyway, that's a secondary issue, but I agree with Dr. John. This is a collapsing lesion, whatever the cause may be. And we know of many viruses, and Helmut Rinke did a beautiful job years ago describing just a ton of things that will give you a collapsing-like picture.
Our feeling was that this collapsing was caused mostly by dengue virus. We can show you some references. There are about, go ahead, Deepika, you can take the control now. So there is a case, and it has come from Brazil most of the time. There are some cases from India and Sri Lanka and from Singapore. The cases have been described. So is macrophage activating syndrome. It has also been described with collapsing glomerulonephritis, one from Mayo Clinic and one from Dr. Degati group has also described a couple of patients. So these are all case reports. Unfortunately, not many biopsies are done in these people. They are thought to have ATN or rhabdomyolysis, and there you go. But I think we should be thinking of, COVID taught us a lot, that any virus can cause collapsing glomerulonephritis. So whether it is dengue or it is a macrophage, I don't know. I treated her as a hyperferritinic syndrome. We did dexamethasone. I was thinking of tocilizumab, but fortunately she improved. She was on dialysis for about a month, and then she was taken off dialysis, and she has stayed dialysis free for the last 2 years, and her creatinine at this time is about 133. I just want to ask Dr. Glassick or anybody else in the audience. We see a lot of CKDU from these parts of the world, like India, and it's a special part of India, Jamaica, and South America. And they have these kind of diseases, and especially leptospirosis. And could that be one of them, along with other environmental causes, the cause of CKDU? Because these patients do tend to stay in some sort of kidney failure, impaired kidney function. So just throwing it out, I don't know. I was just thinking, because the geography is very same with these infections, and they then develop due to other environmental factors, CKDU. Any thoughts about that, Dr. Glassick or Dr. Gradby or anybody else?
Well, I'll give an opinion that collapsing FSGS in the setting of a viral disease is a non-specific reaction to a very strong interferon signal induced by the virus. So you can see it with HIV, with coronavirus, dengue, and I suspect any virus, severe virus infection that promotes a strong interferon response in a patient with susceptible podocytes can develop the lesion of collapsing FSGS. This is why I don't think collapsing FSGS is a diagnosis, because it's a pattern of injury in response to a viral etiology. I think this patient surely has a very strong interferon response because of the tubulo-reticular signals in the biopsy, the signs of inflammation, and I would suspect that this collapsing FSGS is the consequence of interferon combined with a susceptible podocyte.
So you bring up an interesting point. I mean, Jonathan Winston years ago, I think in the New England Journal of Medicine with HIV, showed very nicely that, the glomerular epithelial cells and the tubular epithelial cells would be infected with the virus.
Right.
And that was one of the theories there, is that was kind of what accounted for the lesion, if you will. Yet with COVID, I don't think people were able to really isolate the virus in those cell lines. So do you think that in all those cases, or for the most part, that it is the interferon and not so much the virus?
Well, it's hard to say, Steve, but you've raised the point that Covan, which looks exactly like Hyvan, has no evidence of viral infection of the podocytes, and most of it occurs in APOL1 high-risk allele patients. So I'm of the opinion that the susceptibility of the podocyte due to a predisposition, a genetic predisposition, is the pathogenesis rather than direct viral injury. I don't know whether dengue infects podocytes or not.
I think that's a very reasonable point. And I think the APOL1 becomes very important here because that's how it's all been seen with the other viral infections, as the second hit is the viral infection, and I think that's what Dr. Glassik's alluding to. And regardless of her, of the ancestry of typical Jamaicans, I'd be very, very curious about it, because I quite frankly, the degree of this, I'd be surprised if she wasn't didn't have two high-risk APOL1 alleles.
As an aside, the association with the high ferritin is interesting. I remember Dr. Rodby presented a case at one of our biopsy conferences of a patient with Still's disease and had a very, very elevated ferritin level as well. And her diagnosis was also her pattern of injury was also a collapsing FSGS. I do wonder if there's something more there. I really don't know, but I wonder if it is related.
Actually, that's a great point, Dr. Whittier. We all think that ferritin is an acute phase reactant, but I think it is also becoming a little bit more clear. I've posted a paper later on that it has immunogenic effects, and actually it can cause interferon activity quite a bit. So viral load, I reviewed a lot of literature on this dengue fever from Brazil and India. I don't think viral load is a risk factor. So I suspect it is what Dr. Rabi and Dr. Glassis are saying, that it is most likely interferon-related thing with a susceptible patient. And the second hit is actually a viral infection, whichever it is. And Dr. Sharma actually is chatting. I was present on that conference. They presented a patient for malaria with collapsing glomerulonephritis, and it has been described. And I think if that patient, I'm right, was African ancestry to Dr. Sharma. You can unmute yourself and comment on that.
Yes. Hi. Sorry, my video is I can't use the video right now, but yes, that's true. The patient was African ancestry and was homozygous for APOL1. And the interesting thing was that when we treated, so this patient has severe falciparum malaria. And when we treated the malaria, so the patient got aggressively treated for malaria and the collapsing glomerulopathy. And the patient had a heavy nephrotic range proteinuria, AKI, etc. And collapsing glomerulopathy on the biopsy, and that completely resolved after treatment. So nothing else was needed at that time. I mean, no other treatment of the infection was needed. I'm just curious, in this case, in what phase of the dengue shock syndrome or the dengue virus infection were the steroids started, or like how early?
When she was in a shock syndrome, when I noticed her ferritin, and I knew that it was cytokine storm, so I thought she was a young lady, and dexamethasone was not a bad thing. I think she was not in viremic state at that time. She was in an inflammatory type of state. That's when we used not an early stage, late stage.
I see.
I just checked the New England Journal of Medicine article, and I will directly quote: the 3 highest prevalence of APOL1 high-risk alleles is Jamaica, Ganfuna, Barbados, and Grenada.
That's right.
The prevalence of APOL1 is greater than 10% in Jamaican residents. So the fact that this patient came from Jamaica makes me even more suspicious that.
Well, I'm pretty certain, Dr. Vlasic, but COVID was there, and APOL1 to get it, at least in interior, is a nightmare. We don't do it here. So I have sent it already, actually, and we are waiting when it comes. It took me about 3-4 months to get the approval. Then we sent it, and hopefully it will come back in 3-4 weeks, and I'll update you guys that definitely has to be done. My favorite subject, actually. So this is a 24-year-old girl who actually she's married, she had 1 child, and once she got better, we took her off dialysis, doing very well. So I did speak to her, which I feel is my moral and professional responsibility, talk to her about her reproductive health. I approached her. I just wanted to know what her values are, what she wants to do. So she definitely wanted to have children. So we did talk about contraception, and she agreed that she will wait for 2 years before she gets pregnant, and 2 years is coming. And so we actually went over with the choice of contraception and her. Can you show next slide, please? So this is a slide I took from Dr. Hernanovich's paper, which was published, I think, in 2019 in AJK. There, I should add, she also was mildly diabetic, and dexamethasone didn't help her. So actually, we went with barrier method. We actually went with IUCD and also barrier method condom. So she was using dual contraception. We didn't go for estrogen or progesterone. She is slightly obese, mildly diabetic, and came from a very severe illness. I was worried about her hypertension and propensity to thrombotic embolic phenomena. So we decided that progesterone, I have used it in Jamaica, but I'm not that confident in that. Sterilization was not an option. So actually discussing with her, keeping everything, her values and what she wanted to do with her life, and with her husband, she went for IUD and condom barrier method. And now she has come back to me and she wants to get pregnant, and we took her off all ACE inhibitors, and she's going to see a diabetologist. And my question to I will ask Dr. Androlovich to comment on that, what other suggestions she has for us. Like, I don't see many nephrologists talking about this. I don't see on any conferences which we do, we discuss the reproductive health of the young people. And I think it's very important. I feel really obligated. I'm very big on this, so I always discuss that. But sometimes I see patients from other physicians, they have no clue what I was talking about that. So I feel this is an important topic to discuss among nephrologists. And my other question is, how much APOL1 has influence on preeclampsia in these patients? Because we all remember that there is a higher incidence of preeclampsia, and what does APOL1 genome does it play any role? So take over, Dr. Ronaldo, it is your show.
Okay, so short answer is we don't know as yet of APOL1. You can suspect it. There are some, certainly FSGS doesn't always do particularly well in pregnancy. Moving her towards pregnancy. So an IUD was a perfect choice. That's totally fine to consider an IUD. You mentioned she's off her ACE. I hope she's not off her ACE before her IUD's out, because you want to keep protecting her kidney. And most women with proteinuric kidney disease, you wouldn't take them off ACE until conception. But what really needs to be assessed is, where is she right now? Do you have sort of like a slide that says, like, where's her current status and GFR, proteinuria, hypertension? I know you mentioned she's already a diabetic. All these are going to affect her pregnancy outcome. You were actually quite right, Bajinder, to say to wait, 2 years. There's a very interesting literature that comes from the Mass General that was published by Jessica Tangren that actually talks about the increased rate of preeclampsia, IUGR, which is intrauterine growth restriction and preterm delivery, even after recovered AKI. So interestingly enough, if you get AKI from any cause, and even if it completely recovers, you're still at increased risk for developing placentally based diseases. And that risk starts to sort of mitigate by about 18 months. So for somebody with such a severe illness as you had, then it was right to sort of wait for a period of time to ensure, as much healing as possible. So do you sort of know where she is right now? Can you tell me where she is?
Yes,
is she in my clinic? Bajinder, is she in my clinic already? Do I even know?
Yeah, we are sending it to your clinic. She is actually, creatinine is around 133. Her blood pressure is basically normal, about 120/80. Once she takes her IUD in December, prior to that, I will stop the renin-angiotensin blocking agent, if you agree.
I don't agree. So how much proteinuria does she have?
She has around proteinuria about 1.45 gram 24 hours.
Yeah, so she's not optimized for pregnancy right now. So, the last thing you want to do is stop her RAS blockade until she's optimized for pregnancy. The higher her proteinuria is before she goes into that pregnancy, the worse the outcome that she's going to have. So, really we need a little bit of discussion as to how best to manage her to lower proteinuria prior to sort of entering a pregnancy. So, most of the time we would leave that on till conception for sure. She's a woman who's had a severe illness. You don't know how long it's going to take her to conceive. And, you could be surprised. Women can take a very long time and need reproductive assistance as well. So just leave her on the ACE inhibitor and send her my way. And then we could start managing her and getting her optimized for pregnancy. So I guess I wouldn't mind hearing from Dr. Glasshook. And, so now you have sort of like a collapsing podocyte. And she's left with sort of subnephrotic range proteinuria, but significant subnephrotic range proteinuria. You said about 2.9 grams, is that right?
2.2 gram, about 1,000 cc's of urine when it was done.
So the combination of sort of that picture is not something that's going to do particularly well in pregnancy. And is there other options that we could consider to improve her proteinuria even prior to pregnancy? I don't know if anybody has any comments.
Do you think I should use glucose transport inhibitor in her in combination with that?
We certainly do, because we do want to lower pregnancy lower proteinuria. So you can absolutely put some of that on as well. I guess you consider this as sort of a secondary FSGS, and you wouldn't necessarily find any benefit from immunosuppressive therapy, but you might even consider some calcineurin inhibitor if we can't control proteinuria, because we don't have a lot of options if it takes off during pregnancy. So the best that you can get her down prior would be optimal.
What's her creatinine right now? You said it, and I just didn't catch it.
I think he said
133.
It's not bad.
What is it?
133.
Well, I'll, Michelle, I'll take a stab at a hypothesis here. This patient during her acute illness lost a lot of nephrons that are never going to return.
Yep.
So she has a current state of nephron deficiency.
Mm-hmm.
Some of the less involved glomeruli have probably undergone hypertrophy and may well be sustaining hyperfiltration injury, irrespective of what the creatinine is, because serum creatinine doesn't tell you what the distribution of GFR is among the nephron population. I think this patient is suffering from a severe nephron deficiency, secondary hyperfiltration injury with persistent proteinuria, and the best way she should be managed is to optimize her ACE inhibitor, maybe even add SGLT2 inhibitors, and avoid pregnancy at this point. I don't think she's ready.
But when will she be ready, Dr. Glasshook? Then tell me when she will be ready.
Well, I don't think she may never be ready in the sense of being completely free of an adverse event from pregnancy.
Correct.
But,
No, right. You're 100% right. This is a particularly high risk pregnancy.
Right.
Her risk of progression of end stage towards loss of kidney function during is there.
Right.
Her risks for preeclampsia, IUGR are certainly there during pregnancy. The issue is if this is sort of something she desires, she may not, get better over the years. So if we can lower her proteinuria very aggressively, as you have recommended, and hold that until the time of conception, she may get through a pregnancy, but she has to understand the risks that are coming with her. And ultimately it's her choice, not our choice. She just has to understand what those risks are that she's going to enter into pregnancy with.
Problem is, I think that is, if we keep using proteinuria as the marker, and we use Dr. Glassick's theory as to why this is happening, which I think is right. I mean, this probably is leading to what we'd otherwise term possibly a secondary FSGS if you rebiopsy her again. The reality is proteinuria may end up actually getting worse over time and not better.
Right.
And we see that frequently with normal serum albumins. I mean, we see that all the time in various other situations. So I don't know if proteinuria is the best marker to determine whether she's optimized or not. I think the other issues have to be weighed in, I think, that other than just proteinuria alone, because I don't know that you'll ever get her proteinuria down to less than a gram or less than a half gram.
I think she's very well aware of that she's a high-risk patient. She is already on glucose transport inhibitor. I started her about 3-4 months ago, and but she does plan to take that risk, and she exactly knows that she's a very high-risk patient. Coming back to APOL1, I personally believe that definitely is a risk factor. I did some digging when I was asking myself that question, and I came across 2 papers. One was actually in AJKD in 2019. It came along when your paper came along, Dr. Kandarovich, and they did say there may be a fetal APOL1 may be a risk factor. And then there is a recent paper from South Africa where it's a case control study of 428 patients, and people who had APOL1 had a higher incidence of preeclampsia in those patients. So I suspect APOL1 does play some role. I do agree that it needs to be more
It's just a
worked
little
out.
muddied, Virginia, just a little muddied by the notion that sometimes they're also more severe in their presentation, and that in and of itself also. So we just don't know yet, but I also suspect that it probably is a factor as well in poor outcome, but it may just be because they've got worse kidney damage, and it may be just because they've got worse hyperfiltration injury, as Dr. Glassick's already, as opposed to just the APOL1.
And her
Any other
creatinine
question about this case?
Her creatinine is 133, right? That's about what, 1.7?
1.788, yeah, 1.7.
Yeah, it's pretty high. I think that's a pretty decent risk by itself.
It is. It absolutely is. But the risk goes up dramatically in the context, and I'm hoping my Jason paper gets through this time, and you can read all about it, Dr. Rodby, but the risk goes up dramatically when proteinuria is added to that.
How
So
interesting.
you can have a GFR of 40 and you don't have proteinuria hypertension, and your risk is not that different for pregnancy, poor pregnancy outcomes than actually the women with much more preserved GFR. So that's so I know it's probably not that it's the proteinuria, as you say, Dr. Corbett, but it's a marker of the badness within the kidney that you're not controlling, be it still inflammatory, be it secondary, or loss of kidney mass. So it's a powerful marker for me of how badly somebody's going to do, irrespective if that's what's really driving it. So definitely, Bajinda, just don't stop her RAS. Okay. Leave her on her SGLT2 inhibitor. If there's any room to move that RAS up and better control her proteinuria, the better that you can control it and lower sort of intraglomerular pressure prior to pregnancy. And I'm stopping both sort of at the time of conception. So, similar to sort of renin-angiotensin receptor blockers, there certainly is animal data that the co-transport inhibitors probably are not okay as you go further along in pregnancy. But that does come right now from animal sort of data. But right now we're sort of stopping both sort of right at the point of
Michelle,
Yeah.
so that's really interesting about the super additive effect of proteinuria, but we don't know if that's a modifiable risk factor, do we? Because you're implying if we lower it, it'll improve, but we don't know. Do we know that?
Okay, well, I guess, I could tell you from my many years of doing this that it does matter. Like it certainly matters that, controlling renal disease prior to pregnancy makes a massive difference in terms of pregnancy outcome. I have yet to see sort of any woman with very high grade proteinuria that does well. I've actually never seen, like, the more you go into it, the worse it gets during pregnancy, and it can be quite, the outcomes could be very poor. So whether or not you're sort of saying, is it just the proteinuria? It is a marker of badness. And certainly if you control it, you could, a really good example is lupus. You get your lupus patients less than a gram of proteinuria and they do dramatically better, same with sort of, and it does carry over to other renal diseases.
Michelle, can I ask you a practical question that I've been asked before? Do you send these patients home with pregnancy test kits and have them test themselves every month? Or do you wait until they have their first missed period before you stop the
It actually really depends on how regular they are, right? So, women that are like clockwork with their periods, it's okay. But if they're irregular, then we do monthly pregnancy tests to be safe.
Okay. And how long after conception can you safely take RAS inhibition without producing teratogenic effects?
So you've got about 8 weeks.
About 8 weeks. Okay.
But realistically, most of the studies show that the damage comes between 12 beyond. However, most of us would feel much more comfortable getting it off at the first sign of pregnancy.
So the strategy of stopping RAS in anticipation of getting pregnant is not a good strategy.
It's not, because you know what, Dr. Classic, you don't all get pregnant real fast.
Fantastic. Great.
So imagine, so what we see, especially women with diabetes, they have obesity, they have a lot of things, they're subfertile. And you stop their RAS because they're planning a pregnancy. They don't get pregnant for over a year. They then lose in more mils of their GFR, and you just keep putting them at higher risk. So the approach that is typically taken now is actually to protect them as long as you can until they go. And some of them also, what if they can't become pregnant and then they don't have that baby, and then you've allowed them to lose over the years that they were trying significant GFR. So that's one of the rationales as well for doing it. And also it maintains proteinuria as low as possible prior to a pregnancy. And then you vasodilate, so your intraglomerular pressure does go down in pregnancy. So sometimes, guess what? There's no such thing as hyperfiltration proteinuria. It often gets better, right? Your pressure.
I would also assume that pro-ovulatory drugs are contraindicated.
We do use them. We absolutely use them. There's certainly higher risk again in these women. Anybody with CKD, anybody with significant, underlying kidney disease, they become higher. It's really important to work with a sort of reproductive endocrinologist who's really careful, because there is different doses that you provide of these drugs. There's also, how many embryos you implant. That all matters in terms of safety for these women getting through pregnancy. Again, you don't want a twin pregnancy either. But many of these women are in the care of, reproductive doctors in conjunction with us.
Michelle, what's your comment on using these estrogen progesterone combination contraceptive pill, especially in diabetic? If my memory serves me right, there is some vasoconstriction mediated through renin-angiotensin blocking agent. Is it real or it is theoretical?
So I think certainly, once you are diabetic and you have sort of diabetic kidney disease, then, you do want to sort of avoid it. Probably what's the most important thing to avoid is an unwanted pregnancy, because an unwanted and unplanned pregnancy is more important than anything else. So if she doesn't want an IUD and she doesn't want a, progesterone only pill, because you have to take it so carefully, then you're still better off with a low dose estrogen tablet than nothing. Right. So because nothing's going to be worse than an unplanned pregnancy. So, women that are difficult to control blood pressure, women who have sort of these risk factors, we try to not use it in them. It's more like a second line option. And also some women do know the proteinuria goes up quite significantly. So when we stop the combination pill, sometimes in preparation for pregnancy, we notice an improvement in their proteinuria as well.
Well, if there are any questions for me or anybody from anybody else?
I'll be expecting the referral tomorrow.
Sorry?
I'll be expecting the fax tomorrow.
Of course. I can't look after her. I'm incapable of doing these things. I hope you again emphasize that, Michelle, to our group especially, and the people in the audience, that reproductive health is a responsibility of nephrologists. If it comes from you, it means to a lot of us a lot.
You just became my favorite nephrologist, Dr. Reen.
Okay.
I keep saying that, no one listens.
Oh, I did listen. Okay, thank you very much, Dr. Glossop, Dr. Corbett, Radby, Dr. Vitil, Dr. Sharma. We'll see you next time. I'll send you the post. Okay, thank you very, very much. Bye-bye.
Great case. Thank you.